Topic for the today's session is Streptococcus, Enterococcus, and Pneumococcus. First one is the Streptococcaceae family. The family Streptococcaceae are catalase negative gram-positive cocci. It is arranged in pairs or chains. Streptococcus, Enterococcus, and Pneumococcus are important of the Streptococcaceae family, and according to the molecular structure, Enterococcus is now classified into a separate family, Enterococcaceae. Next one is the classification. On the basis of hemolysis, streptococci can be divided into three groups. First one is the alpha hemolytic, beta hemolytic, and gamma hemolytic. Alpha hemolytic is otherwise called as partial or green hemolysis. The example of alpha hemolytic is Streptococcus viridans, Streptococcus pneumoniae. Next one is the beta hemolytic. It is complete or yellowish hemolysis. Example is beta hemolytic streptococcus. Next one is the gamma hemolytic, in which no hemolysis is seen. Example of gamma hemolytic is enterococci. Next one is the Landsfleet's grouping for beta hemolytic streptococci based on carbohydrate and antigen in cell wall. The beta hemolytic streptococci are divided into 20 serogroups, group A to V except I and J. Carbohydrate antigen is extracted by hydrochloric acid. It is known as Landsfield's method, formamide Fuller's method, enzymatic Maxter's or autoclaving. Next one is the Streptococcus group A. Streptococcus pyogenes is further subdivided based on Griffith typing and M typing. In Griffith typing, it is based on M protein. In M typing, it is based on gene coding. Next one is the Streptococcus pyogenes group A. First one is the cell wall antigen. The activity of cell wall antigen is it has inner thick peptidoglycan layer. It confers cell wall rigidity and it will reduces inflammatory response, and it has a thrombolytic activity. That means it will lyses the platelets. Next, C carbohydrate antigen. It is present as middle layer and is group specific. Next one is the outer layer of protein and lipoteichoic acid, which helps in adhesion. Next one is the capsule. Capsule is expressed by mucocenes. It is made up of hyaluronic acid. Capsule is antiphagocytic. It helps in adhesion, but capsule are not antigenic. Next one is the streptococcal pyrogenic exotoxin or erythrogenic toxin. It has three types, A, B, and C. Type A and C are example of super antigens, and type A and C it is bacteriophage coded. B toxin is chromosomal mediated. Next one is the pathogenic role. It is associated with pathogenesis of scarlet fever, necrotizing fasciitis, and streptococcal toxic shock syndrome. In dictus, intradermal injection or streptococcal pyogen endotoxin, it will produces erythema only in children who are susceptible to develop scarlet fever. Schulz-Charlton reaction, in which blanching of after injection of anti-streptococcal pyogen enterotoxin antibodies. It is used for diagnosing scarlet fever in past. Next one is the hemolysin. It has streptolysin O and streptolysin S. Streptokinase fibrinolysin. It will activate the plasminogen. Next one is the rapid spread. It is preventing the formation of fibrin barrier. Therapeutically used in treatment of coronary thrombosis. Next one is DNase. The DNase is Diagnosis of many infections such as pyoderma and acute glomerulonephritis, it is low. Next one is the other enzymes, hyaluronase. It is a spreading factor. It is expressed by non-capsulated strains such as M type 4 and 22. Hyaluronase, it will break down the hyaluronic acid of the tissue and it will help in spread of infection along the intercellular space. Next one is the serum opacity factor, lipoproteinase enzyme in nature, NADS and C5A peptidase. It inactivates interleukin 8. Next one is the streptolysin O. Streptolysin O is oxygen labile, so it is named as streptolysin O. Hemolysis is seen only in deep colonies. In pure plate, it is seen as it is inactivated in presence of oxygen. Streptolysin O is cytotoxic for neutrophils, platelets, and cardiac tissue. Streptolysin O is strongly antigenic. Anti-streptolysin O antibodies are raised in most of the streptococcal infection. It is used for the standard marker for retrospective diagnosis of streptococcal infection, except in glomerulonephritis and pyoderma, where anti-streptolysin O is titry is low. Next one is the streptolysin O is structurally functionally it is similar to tetanolysin of Clostridium tetani, pneumolysin of Streptococcus pneumoniae, theta-toxin of Clostridium perfringens, listerolysin O of Listeria, serolysina bacillus cereus. Next one is the streptolysin S. It is oxygen stable serum soluble, so it is named streptolysin S. It will cause hemolysis on the surface of blood agar plate. It has a leukocidal activity. Streptolysin S is not antigenic. It is not useful for serological diagnosis of streptococcal infection. Next one is the manifestation. Streptococcus pyogenes, both suppurative and non-suppurative manifestation. First one is a suppurative manifestation. Under suppurative manifestation, first one is a respiratory infection. In respiratory infection, it will cause pharyngitis, inflammation of pharynx or sore throat. Most common cause 20 to 40% of all cases. Pneumonia and empyema will be there. Next one is a scarlet fever is the most common cause and it is rare and it is characteristic by pharyngitis and sandpaper rashes and strawberry tongue. Pastias lion, it is a prominent rashes in skin fold. Pathogenesis due to streptococcal pyogen enterotoxin in which dick test is positive. Skin and soft tissue infections, impetigo will occur. It is the most common cause. It is mostly seen in children due to pure hygiene and during warm climate it will be seen. It is characteristic by pustular lesions that become honeycomb-like crust in which fever will won't be there and it is painless. It is associated with higher M type and nephrogenic strains. Cellulitis and erysipelas is the most common cause. It is tender, bright red, swollen, indurated, pudis, orange texture of skin is seen due to involvement of superficial lymphatics along with fever and chill. Most common site is malar area of the face. It is seen mostly in the older people. Next one is a deep soft tissue infection. Streptococcal hemolytic gangrene is seen. Streptococcus pyogen is the most common cause. Almost 60% is affected. It is a rapidly spreading. Hence, Streptococcus pyogenes is also called as flesh-eating bacteria. Toxic shock syndrome. Staphylococcal toxic shock syndrome is most common, but bacteria is most common in streptococcal toxic shock syndrome. Next one is a streptococcal myositis, inflammation of muscles. Streptococcus aureus is the most common cause of myositis. Next one is a complication, Peripheral sepsis, which is caused by group B Streptococcus, is the most cause. Others such as otitis media, quinsy, Ludwig's angina, pneumonia, post-viral, osteomyelitis, and meningitis will be there. Next one is the non-separative complications. Streptococcal antigens will show molecular mimicry with human antigen. Due to the antigen cross-reactivity, antibodies will be produced against streptococcal infection. Then again, it will cross-react with human tissue and it will produce a lesion. This will account for non-separative complications such as acute rheumatic fever, post-streptococcal gluteal psoriasis, reactive arthritis, pediatric autoimmune neuropsychiatric disorder associated with Streptococcus pyogenes. Next one is the difference between acute rheumatic fever and post-streptococcal glomerulonephritis. First one is the future prior history of infection with in which acute rheumatic fever pharyngitis strains will be there. In post streptococcal glomerulonephritis, mainly pyodermal strains or rarely pharyngitis strains will be there. The serotype of acute rheumatic fever is most of the strains are Streptococcus pyogenes. Next one is the post-streptococcal glomerulonephritis in pyodermal stains of 49, 53 to 55, 59 to 61, and pharyngitis strains 1 and 12. The immune response of acute rheumatic fever is marked, and in post-streptococcal glomerulonephritis, immune response is moderate. The complement level of acute rheumatic fever is unaltered, and in post-streptococcal glomerulonephritis, it is low due to the deposition of glomeruli. Next one is the genetic susceptibility. Genetic susceptibility is present in acute rheumatic fever and it is absent in post-streptococcal glomerulonephritis. Repeated attacks are common in acute rheumatic fever. In post-streptococcal glomerular nephritis, repeated attacks is uncommon. Next one is the penicillin prophylaxis is indicated in acute rheumatic fever. In post-streptococcal glomerulonephritis, it is not indicated. Next one is a laboratory diagnosis of Streptococcus pyogenes. The transport medium is used such as Pike's medium. Under direct smearoscopy, pus cells with gram-positive cocci in short chains will appear. Under culture, blood agar pinpoint colony with white zone beta hemolysis is seen. In selective media, crystal violet blood agar and PNF media is used. Next one is a liquid media, granular turbidity with powdery deposit will be seen. Next one is the biochemical identification. It is catalyzed negative, bacteriocin sensitive, pyrrolindonylene araldimase test is positive. Next one is the typing. First one is the Landsfield grouping. It will show group A Streptococcus. Typing of group A Streptococcus is done by two methods, Griffith typing and M typing. Next one is the serology. Anti-streptolysin O antibodies and anti-DNase B antibodies. Anti-streptolysin O antibodies titer is elevated above 200 total unit per milliliter in most streptococcal infection, except in pyoderma and post-streptococcal glomerulonephritis. Anti-DNase BAB titer, it is greater than 300 to 350 units per milliliter, is diagnostic of post-streptococcal gonococcal nephritis and pyoderma. Other antibodies are elevated on anti-hyaluronase and anti-streptokinase antibodies. Next one is the prophylaxis. For long-term maintenance therapy with penicillin is required for children who develop early signs of rheumatic fever. It will prevent the streptococcal reinfection and further damage to heart. Next one is the group B Streptococcus. It is otherwise known as Streptococcus agaltiaceae. The pathogenesis is approximately it will affect 30% of women or vaginal or rectal carriers of group B Streptococcus. The infection is most common in neonates and in pregnancy. It is a major cause of neonatal sepsis and meningitis. In neonates, it can be understood as a late onset. In puerperal, sepsis will be there, which means infection of genital tract, and peripartum fever, which means fever during delivery. Next one is the infection of elderly people with underlying illness such as diabetes mellitus or malignancy, cellulitis and soft infection, urinary tract infection, pneumonia and endocarditis will be seen. Next one is the lab diagnosis. It can be differentiated from various Streptococcus by following biochemical tests. Chem test is positive.